A very warm welcome to today's webinar, providing vital education and support to the cancer research community during this time of unprecedented disruption due to the global pandemic. Today's session is relevant to the NCRI's Living With and Beyond Cancer group. Their remit is to improve the quality and increasing the quantity of multidisciplinary research into outcomes for people affected by cancer at all stages of the disease. For further information on the NCRI's Living With and Beyond Cancer group and the programme for our future webinars, please see the link posted in the Q&A box. I will now hand you over to Dr. Gillian Prue from Queen's University Belfast, who has kindly agreed to chair today's session and introduce our guest speakers. Dr. Prue, over to you.
So good afternoon and welcome everyone to this session, this our NCRI session on what can we do to reduce the burden of cancer, interventions that work. So my name's Gillian Prue and I'm a reader in chronic illness based at Queen's University Belfast. I have an interest in living with and beyond cancer research and have a lot of work that I focus on is in exercise oncology. So I'm really looking forward to hearing some of the work today. Just some housekeeping before we start. Hopefully everyone should be able to see a question and answer bar that's on the right hand side of your screen. Do please use this for any questions that you may have. We'll run through all three presentations and then have our question and answer session at the end. So type your questions in there and don't forget to like questions that you would like answered, because that pushes them up the list for us as well. If any of you use Twitter, please, and you are tweeting about the event, use our hashtag NCRIVirtual. So we have three great speakers today, and we're going to start with Clare and then move on to John and then Liz at the end. So our first speaker is Dr. Clare Shaw. She's a consultant dietitian at the Royal Marsden NHS Foundation. She's the lead for therapy and research and encourages and supports allied health professionals to undertake research. She's a member of the NIHR Cancer and Nutrition Collaboration and is the nutrition lead for the Institute of Cancer Research and Royal Marsden Biomedical Research Centre. She was also the co-chair of the Nutrition Working Group in the Prehab for People with Cancer report that was published in July 2019. Many of you I'm sure know Clare, and she's published numerous research articles on nutrition and cancer, a textbook, and is also the author of the Royal Marsden Cancer Cookbook. She was awarded a fellowship of the British Dietetic Association in 2016, is the Research and Education Officer for the BDA Oncology Specialist Group, and a committee member of the European Specialist Dietetic Network for the European Federation of the Association of Dietitians. So we're really looking forward to Clare's presentation. So that's over to you, Clare.
Thank you very much, Gillian, and thank you for the invitation to speak this afternoon. Next slide, please. I'd just like to highlight the organisations I'm sort of representing this afternoon. I'm an executive committee member of the NIHR Cancer and Nutrition Collaboration that was really born out of the need to bring together multidisciplinary stakeholders to support more coordinated framework for nutrition and cancer. I also work with the Biomedical Research Centre at the Royal Marsden and the Institute of Cancer Research, again to embed more research of this type into their portfolio. And it's really exciting that we are now looking at, is developing an NIHR Oncology Translational Research Centre. And I will mention a little bit about that towards the end of my presentation. So next slide, please. I really want to talk about prehabilitation, particularly the nutritional component. So prehabilitation, the picture on this slide is the front cover of guidance document that was published in July 2019, and it brought together the NIHR Cancer and Nutrition Collaboration, the Royal College of Anaesthetists and Macmillan Cancer Support to produce this document. So there was an extensive evidence review and then a meeting where we really brought together the guidance and really looked at promoting healthy behaviours aimed at improving both physical and psychological health prior to and during cancer treatment. Next slide, please. So what are the aims of prehabilitation and what sort of healthy behaviours are we talking about? So the rationale behind this is, rather than waiting for people to become impaired by their disease or their cancer treatment, it's about preempting that potential decline and actually improving people's health and resilience through behaviours such as improved nutrition, exercise and physical activity, and psychological support. But underpinning that, we also need to recognise about behaviour change to keep people able to continue with these changes in their behaviour. The report also recommends the development of a personalised prehabilitation care plan, which would run alongside any treatment plan. And the potential benefits from this early intervention are numerous. They could include reduced length of hospital stay, reduced post-operative complications, improved cardiorespiratory fitness, improved nutritional state, and very importantly, enhanced quality of life. Next slide, please. So I particularly, as I said, I want to focus on the nutrition in prehabilitation. Next slide, please. We know that if people have a poor nutritional state, then that does impact negatively on cancer outcomes. Now, this is a poster that I took recently to the ESMO 2020 conference, and it looks at weight loss. Now, weight loss is part of the measure of nutritional status, although it isn't the whole picture. But we know this data was from the National SAC database held by Public Health England, and it looked at 200,000 cancer diagnoses between 2014 and 2017. And there was actually a complete data set on 87,000 patients of different diagnostic groups. And what we looked at here was whether they'd had any change in weight, any weight loss, and looked at changes in their chemotherapy regimen. And you can see from this plot that for some diagnoses, if people lose weight, then that significantly increases their chance of having an alteration to their planned chemotherapy, their systemic anti-cancer treatment. And if you look at the plot, there are particular groups that are susceptible to this, including diagnoses such as carcinoma of the colon, gynae cancers, stomach, lung, and leukemia. Next slide, please. But as I said, weight is only one element of that, and I think we really need to put more of a focus on body composition. So these are the results of a study that was published a few years ago now, 2013, looking at a cohort of people with gastrointestinal or lung cancer. And what they did was they looked at body weight, body mass index, and also looked at slices of CT scans to assess muscle bulk. And you can see on this slide the red areas on those sections, CT scans. They have outlined the muscle groups. Now, for these three women, they have the same body mass index of 29.4, so they'd be in the overweight category. But you can see from those slides that there's actually more than a twofold difference in the skeletal muscle index. So in terms of planning treatment interventions, these women would get the same dose of chemotherapy, but actually their muscle bulk is significantly different. Now, we know that weight loss, loss of muscle, and muscle attenuation, as identified on CT scanning, is all associated with poorer prognosis compared to people who've not lost muscle. And we also know that low muscle mass is associated with an increased risk of toxicity during chemotherapy compared with people who don't have a low muscle mass. So these are really important components when we think about prehabilitation. We really need a focused intervention that is going to affect aspects of body composition. Next slide, please. So I've talked about prehabilitation, but what does it involve? What's a multimodal prehabilitation intervention look like? So this is from a study published last year. It's pooled data from 3 randomized studies, all from one centre. And it's just, I've put this up to outline what we would expect a prehabilitation programme to involve. So it'd be individualised home exercise, both aerobic and resistance exercise, nutrition counselling about dietary intake, possibly using oral nutritional supplements if people are not meeting their nutritional requirements. In this instance, they used a whey protein isolate supplement with the aim of supporting muscle development, and also anxiety and relaxation techniques. And in these studies, the interventions were focused 4 weeks before surgery and 8 weeks after. Now, I think we all would agree that's quite a big ask. You know, for everybody who's made a New Year's resolution in January, would you all say that you're continuing with that same programme at the end of March? So it is quite a lot to ask people to do. Next slide, please. So what effect does it have? Now, this again is from the same paper, the pooled data. In colorectal patients, this trimodal intervention improved disease-free survival in stage 3 colorectal cancer patients. So it didn't seem to have the same effect in stages 1 or 2, but it might be that the study just wasn't powered sufficiently and that wasn't enough. There was a low rate of recurrence in this group. So maybe this study didn't pick up this difference. But other studies have shown similar results. And I'll be very interested to hear from John if he highlights some of these other studies that have also potentially impacted on tumour regression. Next slide, please. So in terms of nutritional component, we know that there is strong evidence that for people who are underweight and weight losing, that we can influence both nutritional status and outcomes by nutritional interventions. Now, what do I mean by nutritional interventions? Giving people dietary advice to meet their requirements, using oral nutritional supplements if required, and in some cases using artificial nutritional support. So you'll see on the left-hand side of this slide, one of the focuses is that we're really trying to avoid malnutrition. But I think in any prehabilitation programme, really important to think about the anabolism. Can we support muscle development, muscle growth? So from a dietetic perspective, as a dietitian, I'm particularly interested in body composition. We don't routinely assess body composition in clinical practice at the moment, but in the future, I see that that is a real role for the dietitian. We need to talk about dietary intake. We need to address symptoms that might affect nutritional status, dietary intake, because we know that ultimately will affect nutritional status. And then we need to think about functional capacity, because it's not worth just giving people who are of a normal nutritional status. We don't just want them to gain fat, we want them to improve their muscle function. So we also need to think about looking into the future. You know, do we need to use other techniques to assess body composition, such as bioelectrical impedance? Next slide, please. So a good question is, does this intervention make any difference to outcome? So this is data from Chelsea Gillis, who is one of the dietitians who was in the prehabilitation guidance group. She published a systematic review and meta-analysis in 2018. And she looked at studies that had used nutrition-only prehabilitation and multimodal prehabilitation. So perhaps the first point to just flag up is that she looked at prehabilitation that lasted for longer than 7 days. And the duration of nutritional prehabilitation tended to be from 14 days to 37 days. So we're talking at least 2 weeks, possibly just over a month. And you'll see from this slide that for nutritional prehabilitation on its own, that was able to decrease hospital length of stay by 2 days. We can also see that multimodal prehabilitation, when the results were combined, they also reduced length of stay by 2 days. So I think it really provides good support to the idea that we shouldn't just be talking about exercise. We should be talking about a multimodal intervention that also addresses psychological aspects. But really, it's not just about asking people to exercise without giving them the nutritional support advice as well. Next slide, please. So we're particularly interested as well in what our patients think. And I know we have Liz speaking later, so I'm not going to talk about this in detail, but just to flag up, we have had a poster accepted for the NCRI conference in early November, and we're going to present the results of 2 focus groups that we ran at the Royal Marsden. Natalie Harris and Emma Nichols, one of our dietitians and physios, really asking people what they thought about prehabilitation, and just some take-home messages. These are the visual notes that were taken during the meeting. We found that people did know the key messages, but they didn't always realise the importance of thinking about them at the beginning of treatment. And the second point is they also needed guidance and confidence to know how they applied to themselves. Next slide, please. So in the prehabilitation guidance, there is this schematic diagram just acknowledging that everybody will have different needs in terms of their individualised prehabilitation interventions. So it might be that some people will cope with what we might call universal interventions, but for many people, because of their disease or their treatment and toxicities that are affecting them, they will need an assessment and they will need individualised advice to make sense of those 3 components, how they apply to them. And I really think it's important that as healthcare professionals, we need to underpin that with behavioural techniques to really support people to keep going with these programmes if we want to influence outcome. Next slide, please. So what is the future? We do have a number of publications in the literature really outlining that in research settings, absolutely we can support people to do prehabilitation. As I mentioned, we really need to think about the benefits of multimodal prehabilitation and not subtracting elements. I don't know what John will have to say, but I sometimes, as a dietitian, I sometimes see people talk about exercise and prehabilitation as the same thing. I think we do have outstanding questions, thinking about the need for us to understand the science that underpins the mechanisms, how nutrition and exercise can influence outcomes. We really need to think about the best ways of personalising interventions. And just to flag up, I mentioned the NIHR Cancer and Nutrition Collaboration is currently working with the new oncology TRC, taking forward the topic of prehabilitation as a priority for future research. And this is one of the key elements in the surgery theme. The overall lead is Angus McNair, who's a surgeon in Bristol, along with Daniel Heff and Dan Elson. So it's really great to see this type of research being prioritised and encouraged by the NIHR funded BRCs. So next slide, please. So I think we're going to get to questions at the end, and I look forward to our discussion. Thank you.
Sorry, just realised I was on mute. I was just saying thanks very much to Clare, and to not forget about the question bar on the side, to keep putting your questions in on that, and we'll get to those at the end. So we're going to move on now to Professor John Saxton. He's a Professor of Clinical Exercise Physiology in the Department of Sport, Exercise and Rehabilitation in Northumbria University. He's a Fellow of the British Association of Sport and Exercise Sciences, a member of the Physiological Society, and has served on the Council for the Society of Research and Rehabilitation. So his research focuses on the effects of exercise and pragmatic lifestyle interventions on wide-ranging health outcomes in people living with and beyond cancer. So he's led a number of randomised control trials and is currently the co-chief investigator of the Prepare ABC trial. which is a multi-centre RCT that's looking at the clinical and cost effectiveness of pre and post-op exercise programmes in patients undergoing colorectal cancer surgery. So we'll move over to you, John.
Thank you. I hope you can hear me. My network connection is not looking good at the moment, but I'm in the sticks in North Yorkshire. But thank you very much for inviting me to present today. I hope this presentation complements that of what Claire has just presented. I'm pleased that she focused more probably on the tri-modal and the nutrition side, because this is all about the exercise component of prehab and the challenges that brings for rehabilitation. But also, just to start off, I'd just like to say a little bit about more generally the role of exercise in cancer risk prevention in primary and secondary contexts. So I have no disclosures. I just want to start with this quote, and this is now widely cited and often gets swapped about a bit in the media, but it says, it was a quote from Robert Salis in 2009, who said, "If we had a pill that conferred all the confirmed health benefits of exercise, would we not do everything humanly possible to see to it that everyone had access to this wonder drug? Would it not be the most prescribed pill in the history of mankind?" And that relates to quite a lot of common long-term conditions, and it also relates to cancer, as we know. So there was quite a large systematic review published by Anne McTernan, or led by Anne McTernan last year, and this provided or showed that there is now fairly strong evidence, well in the range of 12 to 21% risk reduction for an inverse association between physical activity and 7 common cancers, including breast, colon, endometrial, stomach, bladder, esophagus and kidney. So, but it doesn't stop there. There is other evidence for at least another 5 cancers. So evidence is accumulating that a physically active lifestyle does bring a lot of benefit in terms of primary cancer risk prevention. What about survival benefits? So for me, a landmark study was that published by Michelle Holmes et al. In 2005, and I think this was probably the first study that showed that if you're physically active after early stage or treatment for early stage breast cancer, then you had better survival. Well, this brought survival benefits, and you can see that at the top here, it's the same study. So women who were exercising between 9 and about 15 Met hours a week, and if we consider that 10.5 Met hours a week is roughly equivalent to a half-hour brisk walk on most days, so that's it seems quite achievable. You can see the survival benefits that brings. So 40 to 50% risk reduction of mortality with achievable levels of physical activity. And since then, there's been a few more breast cancer studies published. And I'm sure there's been a few more since this slide was developed. There are 2 studies, similar studies in colorectal cancer patients, people treated curatively for colorectal cancer, and we can see survival benefits associated with these levels of physical activity, slightly higher, perhaps 45 to 60 minutes on 5 or 6 days a week of brisk walking would come into those categories. So we have evidence of colorectal cancer. And more recently, we have evidence for prostate cancer. So you can see achievable levels of physical activity, 90 minutes a week of brisk-paced walking, 3 hours a week of vigorous activity, 3 hours a week of brisk walking. So these bring survival benefits for prostate cancer patients. So, and I think there is even evolving evidence for other cancers now. So we can see clearly that physical activity brings benefits in terms of primary and secondary prevention. What are the potential mechanisms? Well, there's a lot of debate about this in the literature. There's some great work going on. And these tend to be the things that are cited in the papers. Inflammatory mediators and adipokines, things like leptin and adiponectin, and those things are also associated with central adiposity. So we have to bear in mind that physical activity does have a role to play in the maintenance of a desirable body weight. Other things like insulin resistance, estrogens, immune function. So there's a whole wad of evidence showing that moderate amount of activity boosts certain aspects of the immune system. epigenetic changes, oxidative stress, antioxidant mechanisms, and reduced angiogenesis. So these are some of the mechanisms that have been discussed, and some may be linked in with the role of exercise in controlling body fat, but others may be independent of that. So that's really about the role of exercise in primary and secondary prevention and survivorship. What about the quality of cancer survivorship? So I'm a physiologist, so I know all about the physiological benefits of exercise, from muscular, motor, body composition, which Clare talked a lot about, cardiorespiratory, metabolic, immunological, molecular. But it wasn't until I started working with patients in exercise trials that I come to learn a lot more about the psychosocial benefits of physical activity and structured exercise. And these are some of them. And we know that life-saving cancer drugs and treatments have adverse side effects. I like to consider these psychosocial benefits as positive side effects. And I think even some of these physiological adaptations can ameliorate some of the clinical side effects of cancer treatment. So there's a lot to gain in survivorship, cancer survivorship, from a physically active lifestyle. So moving on to prehabilitation then. This slide just shows stages of the cancer experience, and from pre-diagnosis through treatment, and then treatment and recovery or end of life phase. And it's this window here that we're talking about when we say prehabilitation. It's this window between diagnosis and treatment that we're focusing on, and that itself brings challenges for exercise prehabilitation. So as a definition, I quite like this one. It's defined as a process on the cancer care continuum of care that occurs between the time of cancer diagnosis and the beginning of acute treatment. It includes physical and psychological assessments that establish a baseline functional level, identify impairments, and provide interventions that promote physical and psychological health to reduce the incidence and/or severity of future impairments. I think the notion dates back to, before that, what do we know? So there's been quite a few systematic reviews published over recent years. This is one published by Sam Orange and others in the UK, and a lot of the systematic reviews regarding exercise prehabilitation tend to have a similar conclusion, that there are lots of small-scale studies out there that show improvements in fitness parameters, walking capacity, cardiopulmonary fitness, prior to surgery if you engage in exercise prehabilitation. But there's a lack of multi-centered, adequately powered trials. And by that I mean trials that are adequately powered to detect changes in post-operative recovery outcomes. A lot of the studies have had generic prescriptions of moderate intensity aerobic exercise, with resistance exercise being less frequent. So there's still a fair amount of work to do in this field. So I'm aware of at least 3 large-scale prehabilitation trials that are going on in Europe involving exercise. So we have a trial, Prepare ABC, which involves 24 UK centres, and this is a trial which is focusing on exercise prehabilitation. It's comparing supervised, vigorous intensity, hospital supervised exercise with support for home-based physical activity with standard care. I'll talk about a little bit more about that in a minute. There's the Westfit trial, which is going on in the south coast of the UK, of England, and this is looking at or investigating supervised exercise and psychological support versus standard care as a prehabilitative strategy. And I think this trial involves more than one cancer type. And then we have another trial in Europe, which is also focusing in on colorectal cancer, but is multimodal and involves 6 international centres. So coming back to Prepare ABC, the main question for us, this is a large trial funded by the HTA. It's been running for a couple of years now. The main question is to ask, can we get patients fit for colorectal surgery? And if so, what are the short-term and longer-term health benefits? So the trial is powered for 2 primary outcomes. Firstly, 30-day morbidity, so post-surgical, post-operative recovery outcomes. We're also following patients up to 12 months and looking at health-related quality of life. We have some key secondary outcomes, one of which is CPET, so cardiopulmonary exercise test to look at aerobic fitness before they start prehab and immediately before surgery. The aim is to recruit 1,146 patients to this trial. And this just to show that we have 24 centres on board, and we're currently at about just under 600 patients recruited. So this is the trial, this is the design. So as you can see, once the decision to operate, patients received a decision to operate, we randomise them. These are colorectal cancer patients who are going to be treated curatively. They're randomised into hospital supervised vigorous intensity aerobic exercise, home supported structured exercise and physical activity, or usual care control. This is before their surgery. After surgery, this top group, they get monthly supervised exercise booster sessions. The second group here, they get monthly follow-up telephone support, and then this group is standard care. The challenge is that all this has to happen within 31 days in the UK. So that's the normal time for decision to operate, and surgery is about 31 days. So all this has to happen within that time zone, and we have to cram in as much exercise as we can get in that particular time window. So with that in mind, this study shows the challenge, because if you're trying to improve cardiopulmonary fitness in a time window of about a month, there are challenges associated with that. This is a systematic review which looked at 48 randomized controlled trials of exercise therapy on cardiorespiratory fitness in patients with cancer. And half of these trials were less than 12 weeks, which means just under half were more than 12 weeks long. And the increase or improvement in VO2 max, peak VO2, was 2 mils per kilogram per minute. And that, in some of these trials, were 3 months long. So, what can be achieved realistically in 1 month? That's a challenge for exercise prehabilitation if we're focusing on improvements in cardiopulmonary fitness. But is that the whole story? I think not, and Clare, I think, showed something similar to this, and this is the same group, Carly's group, and obviously Chelsea Gillis works in that group, and this shows that this study, it compared prehabilitation and rehabilitation versus rehab only. So the prehabilitation, these were colorectal cancer patients. This was the prehabilitation intervention as described by Clare earlier. So the rehab would have started on this in this time zone here between baseline and surgery. This is the prehab group. The rehab group would have started on this after surgery in this time zone. And what we can see here is that the prehabilitation group, their 6 minute, their functional capacity improved prior to surgery. And also it was maintained at a higher level throughout the perioperative, post-operative period. So in some sense, this was trimodal, admittedly, but we can see that it's probably not just about improved cardiopulmonary fitness, it's about improving or providing a better platform for rehabilitation. So this group had less decline in function and it stayed higher throughout, so providing a better platform for rehabilitation. Clare mentioned this, and I'm glad she did, because this group, the same group we talked about earlier, published a lot in this field. They showed that in a pooled analysis of their randomized controlled trials, there was maintenance of lean body mass during the peri and post-operative periods. And we know that this is important. So patients with low skeletal muscle mass have poorer outcomes and respond worse to chemo. So this is an important, I think this is an important strategy for prehab, to maintain skeletal muscle mass, and that may well be benefited by nutrition support as well as resistance exercise or a type of exercise with that aim. This is my penultimate slide, just to say that apart from it providing a better platform for rehabilitation, we did a focus group study. We applied our supervised exercise program, which is the same program that we used for the Prepare ABC study in bladder cancer patients prior to the Prepare ABC study. And we published this, and we did a focus group just to understand what the patients felt about what were the benefits of engaging in vigorous intensity aerobic exercise prior to their radical cystectomy in this case. And there were four main categories of perceived benefits. So physical health benefits, the patients did feel some physical fitness benefits from a short-term program of vigorous intensity aerobic exercise. Psychological health benefits, and I'll just talk about that in a little while, social benefits, and positive motivational experience. They felt they were taking some control. So the quotes, it filled in the time you were waiting to go for a large operation, it filled in the time nicely. You're thinking you're doing something good, you're helping yourself for the operation, so helping their mental preparation for the surgery. The good part was the instructors spend all the time we were there, all their time with us, and that was very encouraging. So they probably get a bit more TLC and a bit more contact with healthcare professionals through prehabilitation before their surgery. But I think from an exercise prehabilitation perspective, I think in the cancer care setting, we have some promising evidence, but there's still lots of questions that need to be answered by robust trials. That will be my conclusion from an exercise prehab perspective. You know, what are the benefits of exercise as part of trimodal or on its own? And just a final thought. So on average, quite a nice quote here. On average, every person will undergo approximately 6 surgical procedures in their lifetime. Statistically, therefore, we are all preoperative. So coming back to the original question, is sooner better than later? I think it seems that sooner is better than later, but later is still so much better than never. Thank you.
Thank you very much, John. That was a really great, interesting talk. We've got some really good questions coming in that we'll address at the end, but we'll move swiftly on to Liz just so that we have time to get as many questions in before we finish. So Liz was a 40-year-old consultant breast surgeon when she was diagnosed with stage 3 breast cancer back in July 2015. She suddenly realised that she had no idea what it was like to be a patient, despite spending her working life treating the disease. She started an award-winning blog to help doctors and patients see what having breast cancer is really like, and now speaks all over the world about her experiences, including a TEDx talk focusing on how to improve the patient experience. And she's co-authored The Complete Guide to Breast Cancer, How to Feel Empowered and Take Control with Professor Trish Greenall, and to help patients learn from other patients about how to cope with everything cancer throws at them. Liz was diagnosed with a local recurrence in May 2018, and side effects of treatment have meant she's had to retire as a surgeon. So over to you, Liz.
Thanks, Gillian, and it's been great to hear from Claire and John earlier. And I must say personally that Claire's book saved my marriage during chemo because I had no idea what to cook when everything tasted horrible. So a personal thank you from me. I want to talk about why exercise should be the 4th cancer treatment. Now, I was a fit, healthy triathlete when I was diagnosed, and I still got breast cancer, so it does still happen to fit people. And I'd gone from being the girl at school who did no sport whatsoever. My maiden name was Ball, but I couldn't catch it or not throw one to save my life, to being a cyclist when I started dating my husband, and I then got into triathlons. And I did my first triathlon 4 months before I was diagnosed. And I just thought, what do I do now? Can I carry on being active during treatment? I had chemotherapy first. I had a big lobular cancer, and no one told me whether I should exercise or not. And this was 5 years ago. It's not that far in the past, but I just didn't know what to do. So I turned to Twitter, and I found an amazing athlete called Fit After Chemo, called Suzanne, sorry, Athlete on Chemo, who was cycling and kayaking and running and doing weights during treatment for metastatic cancer. And I found several cyclists who were still racing and even competing during treatment. And I thought, right, I'm going to see if I can carry on exercising, because cancer had taken my job. It was taking my life, my physical health. I couldn't let it take my spirit. And Kate Granger, the woman behind the Hello, My Name Is campaign, who's no longer sadly with us, gave me advice, and she said, you have to walk for half an hour every day. You'll hate me for telling you to do it, but it will make you feel better. It will reduce the side effects of chemo, and it's the best thing for fatigue. And I hated her for telling me to do it, but I did it religiously, and it made a huge difference to how I cope with treatment. Not just the physical side effects, but the mental side effects, the anxiety, the depression. When I was exercising, I just felt I was Liz. And so I started doing park runs, bold as you like, not wearing a hat, but no one stared, no one cared. And a load of people came up and gave me a hug saying, welcome to the Cuddle Club. I was part of the team of people just out there doing it, trying to exercise on their good days. I would cycle to chemotherapy on my good weeks when it was sunny, and my husband would drive me home. And again, just cycling along those country lanes, I just felt free. But I got bollocked by the chemo nurses who said, your neutrophils are really low, you might get an infection. But really, all that joy I've had from riding my bike on a country lane had just gone because I'd been told off for exercising. Something in me still wanted to see if I could do a triathlon though, and my local cycling club were doing one halfway through chemo, and it landed on my good weekend, and it was in a pool, so it wasn't open water, and I had to beg them to let me do it. I had to promise to be really slow, to be really sensible. If I felt ill, to stop, but they let me. And it took me 2.5 hours compared to the normal hour and a half it used to take. But the feeling I got when I crossed that finish line, at that moment, I was just Liz. I wasn't a cancer patient, I was just me. And I took that one stage further by doing a half Ironman triathlon a year after finishing treatment. And I hate the colour pink. I raced in a big pink neon wig, and I do it for charity because I hate the colour pink. And again, I only just got in under the cutoff, but it was just proving that I can still exercise and I can still get my life back despite everything I've been through. You've heard a lot of talk about the evidence behind exercise being the fourth treatment, and that's for prehab, during treatment and after. And it's all about quality of care. There was a surgeon, I thought quality of care was pretty scars to put up at pictures of conferences and not having many complications. But the third part of quality is the patient experience, and exercise can give them some control back. It can reduce the risk of recurrence. It can reduce the risk of complications. It is so important. If you want to get a great overview of what the evidence is, go to the Macmillan website, and they have a huge PDF talking about physical activity in cancer. Claire's put up prehab, but they have it for during treatment and afterwards. It was great. It will tell you why you need to be prescribing it to every single patient. Last year, the international guidelines were printed from ASCO, and it's a huge group of the experts who all came together, and this is what they have shown. Every single cancer patient should be doing 3 sessions of aerobic exercise, half an hour a week, getting their heart rate up, and 2 sessions of resistance exercise. They're all the benefits you can see. It's physical, it's mental, it reduces the risk of recurrence. There is no reason not to prescribe it. And I think if you don't tell patients to exercise, you're doing them a disservice. But exercise can sound like a dirty word. You know, women have had breast cancer, they've lost their image, their identity, they're menopausal, they put on weight, they've lost their libido, and you want me to exercise as well. How do you sell it? And I think it's telling them this are the benefits it can give. We give chemo to breast cancer patients if there's a 5% reduction in their 10-year mortality. But as John said, exercise can reduce your risk of recurrence by 50%, and it's free. It's huge. We need to tell everybody to do it. How do you assess exercise though? Because everyone says, I don't have the time. As a surgeon, I would have to tell patients they had cancer, examine them, clerk them, talk about surgery, mention possible radiotherapy, consent them, pre-op bloods. There's so much. This slide from Catherine Schmitz, one of the leading professors in exercise physiology and oncology, has given you this that you can do in a minute. A nurse could do it. You don't need medical qualifications. You assess, you ask them, what have you done in the last week? You tell them what they need to do, and you refer them, you signpost them to tell them this is where you can get the information. And that's the hard part, because if you don't know what aerobic exercise to do or what weights to do, you're never going to tell them to do it. And that's where I'm going to give you some tips. I hate words on slides, but if you can screenshot these 2 or make a note. Aerobic training, it can be free with a pair of trainers. The Couch to 5K app, park runs when the world opens up again, YouTube videos. So many personal trainers have gone online during the lockdown. You can do Zumba in your living room. Cycling, tennis, canoeing, rock climbing, it doesn't matter as long as they're getting the heart rate up. Investigate to see if your local leisure centres offer discounts for cancer patients. Have signs in the waiting room telling patients what's available for them. But it's the weights. The weight training is almost more important. Well, if you have metastatic cancer, the thing that will keep you out of hospital is being able to stand up from the toilet and to walk upstairs. And to do that, you need leg strength and you need the protein in the diet to build the muscles. These are simple exercises you can get patients to do at home. Go and Google how to do them. Video yourself or your patients doing them to create a chart, something you can send all your patients to say. You can do a squat at home. You can do rear lunges, holding water bottles for resistance and slowly build up. Now you know what to tell patients to do and why the muscle training is so, so important. I think one of the biggest things, though, is a sense of community. And for me, it was finding other athletes on Twitter and meeting them at Park Run. But in this time of lockdown, it's very, very hard. I'm about to launch a website with 3 others called CancerFit.me, where we've got stories from other patients who've exercised to see what other people are doing and inspire them and maybe drag their families along. And it's a great way of getting that sense of community again and realize you're not alone and you can do more than you think. If you're not prescribing exercise to your patients, you're doing them a disservice. Let them take some control back and lead a better life with cancer. Thank you.
Thank you very much, Liz. Wow, 3 really fantastic presentations, and we're getting some really great questions in. So just in the last 15 minutes that we have, we'll have a little look at some of the questions and see what your responses to them are. The first one that's kind of got the most attention online is from Sam Ahmedzai, who's asked, how has COVID-19 impacted on the ability of the NHS to offer cancer patients a prehabilitation programme? Claire, do you want to sort of take that first, and then John can maybe follow up?
Yes, that's a great question. Well, I think one of the things is, I think in the early part of the pandemic, some resources from cancer were moved to other areas. So I think, you know, obviously there may have been a resource issue, obviously not delivering things face to face. I think therapists did a very rapid move to developing videos, providing online support. Certainly my colleagues at the Royal Marsden, we developed a video about nutrition. Our physios developed exercises people could do at home. And from a research perspective, I was very aware that the WestFit study, the prehabilitation study out of Southampton, that stopped. And there was a lot of activity developing the SafeFit study, which is a prehabilitation study managed through the Macmillan website, providing remote support to people to exercise and think about eating well and thinking about their psychological resilience, but staying in their own homes when people were shielding. So I think there was a lot of rapid activity. But yes, I think it's completely changed the way we look at prehab because we can't do it face to face. The same. John, I don't know if you'd like to add anything to that.
Yeah, I mean, we have actually temporarily suspended our supervised arm in that trial because it's too difficult to run supervised vigorous intensive aerobic exercise at this point in time. So we've had to suspend that arm. In another trial, we've had to modify it for support for breast cancer. It's not prehab, but it's a support for breast cancer patients. It's lifestyle. We're looking at delivering that 100% virtually until we come through the COVID situation. I know it's been successfully implemented in other researchers. They're using real-time Zoom sessions to provide that real-time face-to-face support. Perhaps more difficult in an exercise support situation than probably providing generalized lifestyle physical activity advice. But yeah, it is a challenge at this point in time.
Have you found that maybe sometimes patients are now a little bit more receptive to remote advice and working remotely and using Zoom and those different online things that perhaps maybe before COVID we wouldn't have been maybe quite so confident in moving to those types of platforms?
I think definitely. I think people are more savvy with that the technology, definitely. But we have to make sure it doesn't reinforce health inequalities, though, don't we? That's the issue, because people may not have space, they might not have the technology. So we have to be careful of that as well, I think.
Yeah, absolutely. I'm going to move on to another question just because we have so many in such a limited time. So, Claire, there's one probably here for you that's asking, do we have any information on the role of specific deficiencies? So, for example, specific vitamins in cancer survival?
Oh, I think we could run another webinar on that probably. That's difficult. I think the headlines are there is that we know that general supplementation doesn't reduce the risk of cancer. I think there's a lot of interest in vitamin D. We know in certain diagnostic groups, low vitamin D is linked to a poorer outcome. That's a bit more complex because it's not just diet, it's exposure to sunlight. So those are the sort of headlines that spring to mind on the vitamin question.
There's another one here that's asking about what role does the gut biome play in cancer outcomes, and are there any prehab intervention studies looking to improve gut health?
Oh, that's we could have another webinar on that as well. So gut health, that is a very complex one. I think the biggest area of interest in gut health really is its potential interaction with some of the immunotherapy treatments. And I think that is an area to watch for the future. I'm not an expert in that area, but I do know there's a lot of interest in the way the microbiome interacts with the immune system and then possibly the way in which immunotherapy works. But I don't think I'm not familiar with any other studies that talk about the microbiome and prehabilitation. But I'd be very interested if there are people out there that could perhaps speak on it.
They can get in touch.
Yeah, definitely. I think that'd be a fascinating one.
Yeah, super. John, there's one here for you from Anna Campbell, who's asking about what do you think of HIIT, so high intensity interval training as a prescribed exercise mode pre-surgery and during chemotherapy.
I read a paper, I think, in breast cancer patients the other day. It's only a feasibility, but it was feasible. And they did show, I think, 3 mils per kilogram per minute change in VO2 max, I think, which is pretty impressive. If we talk about HIIT as all-out sprint type training, I think we do have to be more careful than what we're doing, which is vigorous 60 to 80% of maximum. So it does bring in extra safety considerations, and definitely I wouldn't do it unless it was in a very safe hospital environment with a crash team nearby and all that, you know. So, but I think there is potential for HIIT, but you know, I've read all the stuff about how painful HIIT can be, and is it really sustainable? Will patients really like to sustain that kind of high intensity, you know, more painful exercise? Liz, would you like to say something about that?
Yeah, so Anna is amazing. Hi, Anna. In Denmark, everybody gets a personal exercise program, and they were in the gym, and the oncology nurses didn't think the patients could do it, and they took the nurses to the gym and realized that the patients are fitter and slimmer than the nurses. Unless you're actually having treatment or you're post-surgery, you can push yourself really, really hard. And I think if doctors and nurses don't do exercise and are scared of working hard themselves, they think, oh, patients can't do it, they've got cancer. But prehab patients are still actually fit and well because they could have had cancer for years and years and years. On your good days during chemo, you can actually work quite hard. And it's actually, there's no reason why they can't work really hard and train and get fast and strong.
Liz, you were fit though, weren't you, before you were diagnosed? You think yes. A lot of the population is sedentary, overweight. You have to bear that in mind, I think, as well, perhaps.
So I think it's getting fit for them. A lorry driver in a bus isn't going to go and run as fast as I could, but he can run fast for him, his relevant heart rate, and exceeds exertion. People don't want to push themselves. You push yourself to your own limit, but actually you need to be pushed to see the gains. A gentle walk doesn't cut it.
I wonder, there's a question here that's asking about in acute disease, there's little time to prehabilitate before treatment starts. What can we do in these scenarios? I wonder if there's some sort of role for HIIT there with the maximum benefit in a short space of time. What do you think?
So I know there was a study looking at lung cancer patients and elderly men having a resection, and 2 weeks pre-op they put them on exercise bikes at about 60% VO2 max for about 20-30 minutes. The men on the bikes got out of hospital quicker, had fewer infections, had fewer complications, and that was just 2 weeks of relatively gentle cycle training. anything is better than nothing, and it tells them they will carry on.
Yeah, go on ahead,
Claire.
Claire.
Yeah, and I was going to say for nutritional interventions, we use cut-off of 2 weeks. You know, if somebody is nutritional depleted, we might not see changes in body composition or weight, but some studies have demonstrated improvements in muscle function. So 2 weeks would be appropriate for nutrition as well.
Super. I'm just scrolling through some of these questions to try and get through as many as possible. We've got a question about prehabilitation trials providing supervised rehab on top of prehab. Why do we assume prehab alone is sufficient to change health outcomes, and why are we not providing rehab too? I don't know who wants to take that one.
I think the work of that we presented in presentations, Gillis and Carly, I think they show that if you start the exercise early in a prehab sense, you get better compliance to rehab actually. So it makes sense in that regard. But I totally agree. As soon as the patient is ready, we should be providing some support in a rehab sense as well, making the most of that platform for rehabilitation that you've established in the prehab setting. I think makes a lot of sense to me, certainly.
And just to add, when we did our focus groups, one thing that really came through very strongly is that people wanted to know how they could monitor themselves. So if they felt motivated and able to carry on, how did they know that they were still doing the right amount? And if they were, they appreciated that healthcare professionals may be very busy, you know, with other patients, but they felt there was some element of self-monitoring as long as they had a safe framework for that.
Yeah, I agree, and that was one of the things that came out of our qualitative work with the bladder cancer. They liked the fact that we were giving them physiological information back and showing progress, and it was a motivational factor. And if you can teach them some skills about how to monitor, even if it's just a Borg scale or something like that, you know, that they can use for getting the right intensity, I think that's very beneficial.
Yeah, and as you said, John, in the Chelsea Gillis's study, the prehab was 4 weeks before, but they continued 8 weeks afterwards.
Yeah.
Yeah.
I just want to ask this one. I think it's a really important question just to end on. That's someone has put in that they've been delivering our programme Move for You for cancer patients across North London for the last 5 years. It's forever challenging to keep the programme funded. How can we use the evidence and drive physical activity to be the fourth cancer treatment? And how can we show the cost effectiveness to those that fund the initiatives?
That's a massive question, and it's something I'm wrestling with for so long. You know, we keep getting the evidence, we keep providing the evidence, and as scientists, we have to keep providing the evidence and lobbying, I guess, the commissioners and this and that, and engaging commissioners as part of your trial steering committees, maybe, and you know, we're doing all that, but it is a challenge. Have you got any thoughts, Claire?
Well, I think the fact that the Oncology TRC, which is just setting up, has taken this as one of the priorities in their surgical work stream, I think really will help us start to build that stronger evidence by, you know, looking at studies across a number of sites around the country. And that's the only way we're really going to build up the evidence that shows the real impact of these interventions. And
people like Anna, I know Anna's online, Anna Campbell doing rehab training, so making sure that we have more specialist exercise and prehab trained people out there to deliver this. That's all important as well.
Yeah, because it's so important to take the evidence and look at it from an implementation perspective and how we can actually get these interventions into the real world and into the NHS in that way.
Yeah,
so
and maybe in this online lockdown world, a lot of it could be done virtual to save the money of actually having in-house programs. I'd love every single cancer patient to be seen by an exercise physiologist or PT, can rehab train, but to give them online programs so they can take that and live the rest of their life. Go and do this for life. Let us show you how. Come back for a top-up if you need it, but it doesn't have to be in person. We've seen that with lockdown. People have carried on training without gym. So is this a chance to go think laterally?
Yeah, I think you're right.
What we need. The money isn't there. It's never going to be there.
No.
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 And having cycling turbo bikes in outpatient waiting rooms, you know, when people are waiting, tell them to do laps of the hospital, get on a bike, just make it part of being in hospital normally.
I love your enthusiasm, Liz.
Yeah, so do I, Liz.
I
It's
keep
great.
banging the drum, but it's just, we need
Brilliant.
to do it ourselves. We need to have the videos of us doing the exercises, because if we don't do it, you can't possibly tell your patients to. As you said, we're all in prehab, John.
Yeah,
in our next
yeah.
NCRI, in the next webinar, we'll do it all on exercise bikes then.
I should get everyone to stand up and do squats now. I'd do that if I was live, but I'm not, so I'll ask you after I've gone.
Right, well listen, thank you very much. I'm sure we could probably all talk for another hour on these topics, but just with the time we need to wrap it up now. So thank you very much, and thank you to the three speakers. Thank you very much to everyone who's engaged and put all the really good questions online. It's been fantastic. Just a reminder to complete the survey. It's also, the link should be in the question and answer. Also take a look at the NCRI website for our full virtual series programme. And thank you all very much for joining us.
Thank you. Bye.
Thank you. Bye.
Bye.